we have any questions? Does anybody have any questions at all? We're wrapping up for today. So
There's a couple of questions in the chat.
perfect. Okay, great.
All right, so this question is from Jennifer. Can the larger catheter on a newborn cause internal swelling? Not sure who to vet that to.
So you have to be in newborns, but you have to be very careful of the size. So you have to get the balloon can cause damage. So if you're using an indwelling catheter, you have to be sure it's secured to the thigh very carefully, because sometimes it's just dangling and it can pull on the bladder neck and cause damage. You want to just use usually you just use the size that's appropriate. And sometimes we try a little bit large one, but it causes a lot of discomfort. So you can also cause damage to the urethra with the catheter. As I was reflecting on what I said, I showed you at the end a number of ways to drain the bladder. Remember that probably at least 50% don't need, they just urinate on their own. They may retain urine, but many children with Prune-Belly syndrome and these issues do not need catheterization, or not regular anyway, but they just need close monitoring of their bladder function and kidney function. Kidney appearance by ultrasound, and things can change over time. So the way that if it's doing well at 2 years, it can change over the next 6 months, or especially with intervening UTIs and so forth.
Thank you so much, Dr. Elder. And I have a question for you after, but Dr. Adams, the way that you went at the approach of trying to improve contractility of a smooth muscle in visceral organs, which is great to hear the differences between the vessels and the organs, and we cannot treat everything the same way, and gives me a lot of hope of how, I understand you had a lot of understanding of how contractility signaling worked in the smooth muscles in the bladder. Did you get to this protein and pathway through a proteomics agnostic analysis, or was it known and then you went and investigated the whole mechanism and how to get it to drug?
Yes, so the signaling of neuropilin-2 to ROROC, that had already been known. So the schematic that I was showing was from a paper developed through Michael Klagsbrand's lab. So he was actually the first to show neuropilin expression on vessels, because prior to the late 90s, this had been studied mostly in the nervous system. And so this notion of sort of modifying the cytoskeleton, that had been known. It'd been studied in endothelial cells, in tumor cells, that kind of thing. It was when we saw the image of the reporter mouse, and people had simply ignored all of this stuff in the abdomen, which again, that's not a surprise to me. It's like, oh, it's the bladder, yeah. So, but when we then look back in the literature, there had been very clear evidence for neuropilin-2 expression in the GI system and in the bladder in the late 90s. So it had been commented on, maybe 2 sentences in one paper. The mechanistic stuff, as I said, that sort of predated our study, but Diane Bielenberg actually came out of the lab that published that paper in 2008. And so it was just, I think ROROC signaling is certainly part of the mechanism. I think there's more, and that was why we were excited by circuit 2, which, you know, if that is increasing with neuropilin-2 deletion, it sort of fits with the idea that you can drive your calcium reuptake, so that could go faster, and that might fit with the increase in evoked contraction. hope that answered the question.
Probably should talk about proteomics analysis of patient samples that
Uh,
we've been collecting for years, and also mouse, because we have the ability to correlate if they are translating
Yes,
the
yes.
little guys.
Yep.
May I ask another question to Dr. Elder? Dr. Elder, how frequent in a patient that has hypotonic bladder, MSMDS, beyond the Prumbelli cohort, how frequent do you recommend that you get urine samples to check anything, or renal ultrasounds, as you just mentioned?
So thank you for that question. It depends. Early on, we do it more frequently. Like it depends on if the kidneys look normal, then you can, it may be a little bit less often. If they're not having urinary infections, it'd be less often, but you need to do a baseline evaluation. If there's moderate hydronephrosis, you do want to watch it pretty carefully. You want to check renal function, you know, get creatinine. I don't know if Dr. Tan gets cystatin C, or that's one of the newer things, but you need to monitor it pretty carefully. And as they get older, you sort of figure out how they're doing, and you can maybe extend it out, but you do have to make sure they come in regularly. And in terms of if with an infection too, if they get symptomatic, you figure out most kids with this will have symptoms, either a fever if they have a kidney infection, or a lower pelvic pain with bladder infection.
Yeah, I'll echo those sentiments. It's hard to actually come up with an actual, like, how often we're going to do it, but in the younger kids, we do it more often regarding ultrasounds and lab testing. In regards to kidney function, yes, we like to look at things like urine output, growth, blood pressure, urine studies to assess for kidney function. But if we actually want to assess chronic kidney disease, if I showed on my slides, it's creatinine is a good marker, or the most common marker, but there are better markers now. Cystatin C is something that we're starting to do more often now to assess kidney function. So we have a lot of clinical markers and then lab testing to look at kidney function over time.
Since we know so little about the disease, I think everyone should get a nephrologist and start monitoring the kidneys beyond the bladder issues, guys. Like, this is part of what we are learning. And thank you for coming to the community and teaching us. Yeah.
We Dr. Tan and I often, and our others, we often see him at the same time. It's same, at the and together so that we're knowing what each other is thinking and doing,
Yeah.
recommending.
Ideal. And hopefully you can ask and replicate whatever you have your care. Dixie, there were questions in the chat for the other session. I have a question.
All right, Rachel from Denver is asking or stating that she's utilizing pelvic floor therapy to help with urology and GI issues, along with bladder emptying through Mitrofanoff. Is this being used anywhere else successfully?
You want to pass it to Dr. Albert?
We do pelvic floor therapy. It's in select cases, it's I think it's helpful. It depends on how you define pelvic floor therapy. So there are different ways, but it is you want what you want to. Some will have a program an active program where you're monitoring the relaxation and contraction of the external. I'm sorry.
Grab it from the middle.
Oh, sorry. Okay. So there you can do biofeedback in a way, which is a way to teach children to try and relax their pelvic floor muscles. You use EMG electrodes on the around the anal sphincter to measure the external sphincter tone, so that you can sort of teach them, some of them, to be able to relax, so that the bladder can empty better. And there are a number of other treatments. There's also Botox is sometimes used in the anal sphincter. We use it some. We wouldn't use it for a hypotonic bladder, but we use it. Sometimes it's used in the sphincter. So there are a number of other methods.
So this question is kind of complicated, and I just want to preface it. One is for you, Dr. Elder, but also Dr. Tan. I'm not sure who, if you guys both want to chime in, but I'm so confused on where to look right now. I guess we're on opposite sides of the room. So I'm just going to look forward. So one of our organizational goals with the Active 2 Alliance is to start reaching out to, hospitals and talking to neonatologists and pediatric urologists and everybody we can to find patients, because this community, the size has doubled in the last 4 years. And we know that there are many more out there. We just haven't found them yet. And so, looking at your presentation, Dr. Elder, on the kidney disease, so frequently what happens with newborns and MSMDS is they're born and they're so critical that something like circumcision is overlooked because it's the smallest thing that anyone really cares about at that point in time, because we're dealing with lung disease or other issues. So it doesn't get done, and then the child gets older, and then no one wants to do it because it's harder on them when they're older. So with that data that you said about getting UTIs being 10 times more common for kids who aren't circumcised, should we, and let me also say that we know that anesthesia is a huge risk for our kids. Should we be advocating from an organizational standpoint for circumcision in the presence of MSMDS with megacystic bladders? I'm not sure who the best.
In terms of finding patients, I think that's a really good cause. And I think the major thing is that you need to have a suspicion to do genetic testing, right? So I think if you get it out there and people are aware that if you have a child who presents in this manner, who have these clinical symptoms, we should do genetic testing. I think I'll advocate for any child with any systemic disease, multi-organ disease, we should consider genetic testing, because you might find something that you wouldn't otherwise be thinking about. So as genetic testing becomes much cheaper, we can do panels, we can do whole exome. That's now less than $1,000. I think that's the way to find patients. So I think advocating for neonatology groups and subspecialties who are access or comfort or access to genetic testing, I think that's something that will do and become more prevalent. In regards to the circumcision, I think that's a more tricky and nuanced thing. I think advocating for circumcision in certain cases makes sense, but putting a blanket statement on every child who has the syndrome should get a circumcision is a little hard. I think Jack would agree that we like it if we know the patients have increased risk for infection, but not every child who has MSMDS will have reflux or risk of infection. So it's going to be hard to necessarily put a blanket statement on that. So I think getting them identified and evaluated makes sense. And then we can individualize the recommendations regarding circumcision.
Hi, I'm Tyann. I'm Levi's mom. In his presentation, he also had said that it reduces the risk in the first year of life. Is there any evidence that it reduces the risk of UTI after the first year of life? Because I've always heard after the first year of life, but if the kid's over a year old, would circumcision even do anything but put them at risk for a stroke, putting them under anesthesia?
So that data regarding risk reduction comes from all children, right? With just all children, healthy children. They note that those who present with febrile infections, it turns out to be UTI. It's a 10 times greater risk in those small infants who are uncircumcised compared to boys who are circumcised. Regarding patients who have increased risk for infection due to an underlying genitourinary tract malformation, like patients with ACTA2 mutations, the risk is going to be just much higher if they already have reflux and it's not going to go away, or they have a bladder that's not going to empty normally, right? You're at increased risk for infection. So there, if you do believe that the risk of infection is not going to go away anytime soon, then circumcision, regardless of whatever age, we do know it's going to reduce risk. We're going to recommend that. And of course, you have to weigh the risk and benefit with anesthesia. And that's why you have a discussion with your urologist and the nephrologist, because you could say, maybe we'll just watch and do prophylactic antibiotics. Or if we get a UTI, we'll just treat it quickly, right? So I think we're not going to force it on anyone, but we'll just lay the facts out there and you can make a decision. But in regards to circumcision at age greater than age 1, yes, if you already have an increased risk, then it will reduce that risk. Hope that answers that question.
I'll add two little things here from the multi-system. We're more aggressive at treating infection and prophylactic in this condition, not only from the reasons that Dr. Tang was mentioning, but also because when they are infected and sick, blood pressure can go down. So we don't want them very sick. And sometimes they don't give you the symptoms, the classic pain and fever. Sometimes what the first thing that they do is lower a little bit the blood pressure. And what it will be tolerated in another kid may not be tolerated in these kids. And it will depend on the case.
And I'm sure Dr. Carroll would appreciate if we don't send him kids with hypotension to the PICU.
And another wrinkle, some of the urinary problems are coming from the brain. We just talked about white matter injury being there in most patients, and that could be contributing to some regulation of the sphincter and the relaxation and all these things. So to make it even more case by case, that's the whole point that I want to make, is that you need to know your contribution from possible urogenic bladder, we call it, from a brain injury perspective, from stroke, from white matter injury versus the low tone of the bladder versus a kid that had a very torpid course with hydronephrosis. So we really put the whole patient together. And in this, you guys are the experts, the parents, because you know your child best. So bring these questions to your clinicians so they can think as a team together and get all the information that is needed.
I have a question. My name's Cheryl, and I'm with the ACTA2 Alliance and YGSA. So it's probably a combination question also to involve Dr. Mussolino. But building off Dixie's question about being circumcised, as you as a group go and put together guidelines for treatment, formal guidelines, that will obviously help with generating awareness and helping to identify patients early, especially with the dilated pupils. But if a patient is born and the dilated pupil is noted, so to Dr. Mussolino's point earlier about newborn screening, as you build out these guidelines, will circumcision be part of the guidelines that you would consider? So if a patient is born and they do have the dilated pupils and we find out early, is that something that maybe to be considered as something to be included in the guidelines? Anyhow, I just wanted to raise that.
Yeah, I'm sure Jack also has an opinion, but I think, yeah, if he wants to talk about it, but I think if we identify a patient, then I think we have to do an evaluation on their GU system. And then based on the evaluation, I think we can have a yes, no circumcision kind of thing.
Yeah, so most of these mothers, when they're pregnant, are having multiple ultrasounds. And so if there's urinary tract dilation, then, and they have this other finding, then I think it's reasonable to suggest it. You know, it's shared decision-making. I'll just, we have a patient here in our system who has was born with urethral valves, which is sort of like, it's a little more serious than prune belly, but this family was adamant against getting him circumcised, and he had 3 or 4 kidney infections over the. He had chronic kidney disease. It wasn't that severe when he started, but he had 3 or 4 kidney infections, and now he's on a transplant list, and he's about 8 or 9. And so they tried prophylaxis, and it still didn't work. So, I think to me, I tell families it's like a vaccination. So it's not going to necessarily 100% prevent it, but if they have these risk factors, which include incomplete bladder emptying or ureteral dilation, whether it's from reflux or pseudo obstruction at the down by the bladder, they are at with the stagnant urine, they're at increased risk for infection. And it's just so again, I'm not a circumcision advocate. I do circumcision in the office up until 6 months. Today I did one on a 5-month-old and a 4-month-old, and under local anesthesia in the office. So a lot of places, they just say, well, you're over 30 days, or we can't do it, or they sort of push it away, don't want to do it. But there are some of us around who will do it because I want to avoid anesthesia.
So the answer to your question is yes. I think certain criteria met, we can answer the question on whether circumcision is recommended or not.
Testing, going back to the NICU, with genetic testing. With the genetic testing, going back to the NICU, sometimes they have to specifically look for something because sometimes their genetic panel that they do won't even catch this. So there are certain diseases or syndromes, they have to specifically look for it. So your broad, I guess, how would you go about, going to the different NICUs or whatever, reaching out to them besides the dilated pupils and, all the other clues?
Good question. So in this syndrome, we're actually fortunate that it usually affects multiple organs, right? And so when you're starting to affect multiple organs, and if you see there's prenatal urinary tract dilation, for example, you already are in a category where you know that the GU system is involved. And therefore, we know that there are many people who are experts in this field that already recognize that if the GU system is involved, plus any other system, you're already going to be expanding your search. And there are now panels that are not just 5 genes, 10 genes, but like 400 genes. And so I think if we can look at them, this ACTA2 will be included in that. And I think you just have to hopefully get somebody who's interested in genetics enough to know that if the panel is not comprehensive enough, it doesn't include all the genes that could include each system, then you do something like whole exome, which sequences all of the coding sequences in the entire human genome, at least all the coding portions. And that is still now relatively cheap. So I think the longer we go, the easier it is to get genetic testing. It's going to become more prevalent. And nowadays, insurance companies are actually covering it. It's actually not that hard to get it done. So hopefully it'll become less of a barrier to get it sequenced and have this gene or any other rare gene included. Because I think now the paradigm of you go to a geneticist, they look at the patient's clinical presentation, and then they say, okay, based on what you look like, I'm going to send this X test. It's reversed now. You are presenting with X symptoms. We just do the genetic testing, and then we figure out whether it fits. Because it's so much easier to do the genetic testing and let the test inform us on what the patient is and see, does it match up with how the patient looks, rather than looking at the patient and seeing what genes fit. We do it the other way around now.
Yeah, and just to add to that, I think a lot of NICUs are shifting towards what's called exome first sequencing. So they're, just as Dr. Tan was saying, taking a child with multiple congenital anomalies and going ahead and just doing a broad-based test first.
Any other questions? Yeah.
So I honestly have no idea who this question is for, but you guys are talking about genetic testing and in the NICUs, and how would you propose that these things don't get missed for a kid who doesn't go to the NICU when they're born? When everything is missed at birth and the doctor looks at the eyes and misses the huge pupils that don't constrict, and like they don't go to the NICU. They go maybe to a special care or something for a little bit, but they don't go to like a NICU for a long extended period of time. How would you propose we don't miss the diagnosis?
So
That makes sense.
yes, it does make sense. I think luckily for us in regards to this diagnosis, the DNA doesn't change, right? It's always there. So whether you miss it in the first day of life or prenatally, it's not going to change. So eventually, whether it's be the ophthalmic, with the pupils, or whether you have finding a murmur and then you get found with a PDA that's persistent, whether you have lung issues or GU issues or GI issues, you're going to present somewhere eventually. And so then the outcome won't change because you will present to care. We will, just to advocate that people do an examination, and when things then start to fit in, and as a family member, you might say like, I have all these issues. Like there must be something unifying. Something's like not right. It's not that my child is 6 different separate issues. Something must be causing all of it, right? And eventually you'll get to someone who's like, okay, we should do genetic testing. And you can do that in genetic testing at any point, at any time. It's not going to change. Whether it's a week old or 80 years old, we can still get the diagnosis. Does that make sense? Okay. Earlier, you just hope that whoever picks it up is willing to help go down that odyssey and find the underlying reason and order the testing.
Yeah, and just to expand, one of the keys to being to having a gene included in a newborn screening context is a therapy. And so if you have a therapy that's outside of standard care, you can advocate for newborn screening on that basis. And so it's one of the things that we need to do is have a therapy that's different than what doctors, are doing right now.
All right,
Warren.
a lot
can
of
I
really
say-
good.
Oh, can I say one thing?
Please.
I just want to say that these are all great questions, and the average time it takes for a family, typically with a rare disease, to get diagnosed is 5 to 6 years, and sometimes it can be more than 12 to 20 years. The work that this group and one of the reasons why we are here as a conference and all the work that has been done by the ACTA2 and YGSA community that you are all now a part of is to help make these things happen. Like the newborn screening, these conversations, these questions that you're having, you're all part of helping to build a patient advocacy group that is going to drive awareness. And we are very fortunate as a community to have all these doctors in this room with Dr. Lindsay and Dr. Mussolino and all the doctors that were here today. But I just want to give a shout out to the ACTA2 Alliance and YGSA, because unfortunately, when you have a rare disease, you are your own advocate. We all know that. But as a group, which is why Rebecca mentioned at the beginning, the us, there's the together part. It's us together. It's us asking these questions, and us as a community that you're going to start seeing more and more from our group about asking you to get involved in these things, because we're really pioneering here on what we're doing. And so keep the questions up, but we will probably be following up with you to help be part of some of these things, to make these things happen so people know more about this disease.
Good point, Cheryl. Thank you.